Dr. Ramakrishnan to come and talk about immunonutrition, and he's going to speak that there is a need. So over to Dr. Ramakrishnan.
Good afternoon. Always a pleasure to be part of Apollo Advanced International Clinical Nutrition Update. Before I start, just want to ask you all a quick question. Is there anyone here who thinks that we do not need immunonutrition? Not even my opponent. So do I need to speak? Okay. All right. What we will do in the next few minutes is scream and debate whether we really need immunonutrition, because the nation wants to know, is there a need for immunonutrition? Now, unlike the fact that I have to work with a moderator who wants people to scream, I know I now have a person who is scientifically very sound, very balanced, who speaks the truth, the whole truth, and nothing but the truth, and therefore would also agree with me that there is a need for immunonutrition. There's no question that there is a need for immunonutrition. The question is, when do we need it? How do we use it? Now, I'm going to have this debate with Dr. Shishir, whom I have not met before, just a few minutes back. And he's a surgical oncologist who's going to say no, which is surprising. If somebody should say no, it's me as an intensivist, because there are a lot of situations in ICU where we should not be using immunonutrition. However, he's going to speak no, so I'm curious to see what he's going to say. So I'm probably going to speak surgical oncology, and he's probably going to speak ICU. That's exactly what the goal of this entire debate has been. Now, what is immunonutrition? Without going into the detail, obviously we are trying to add some nutrients, contents which are more than what is normally encountered in the diet, primarily to modulate or boost immunity. And this seems to be acting predominantly on the mucosal barrier function, the cellular defense function, and also the local or systemic inflammatory response. And that's where the big question comes on when to use it appropriately. And what are the common conditions in the hospital that we encounter where people have low immunity? Number one is trauma, accident, burns, where there is a drop in immunity level. Any kind of illness or stress, and in the ICU, we see it significantly in the critically ill patient, in the post-operative patient, in any kind of surgery where there could be stress, and of course cancer. And all of this is exactly what Dr. Shishir deals with. Now, in the ICU, we do not deal with a homogeneous population. I mean, we could have one person who's an overdose, another person who's a post-operative patient, the third one could be a coronary event, any of those. So we have a mixed group, whereas in the post-operative group, it's more usually homogeneous in what is encountered. So what happens in a surgical patient, particularly when an elective surgery is planned? A lot of changes in the system, but the one thing that I wanted to focus here is the fact that the specialized immune myeloid suppressor cells, following any kind of insult, particularly in the surgical population, rapidly increase the arginase 1 level and therefore deplete arginine. So when something is depleted, we are trying to replace, and that's the logic in which we are wondering whether immunonutrition could help in this group of patients. Now, what does this inadequate arginine do? It depresses the T cell function, it can affect the microcirculation, it can lead to multisystem organ failure, and there are other things that we are looking at, and Anupam mentioned that formulas containing not only arginine but also omega fatty acids seem to somehow overcome these regulatory effects of the myeloid suppressor cells, which is what we are concerned about in this surgical group of population. And therefore, we try to deplete the arginine levels, we try to inhibit the arginase level, and that's what we try to do by restoring the immunocompetence using the immunonutrients. Now, as early as 1992, there were studies, and it was an 85-patient study where they looked at patients undergoing upper abdominal surgery for GI malignancy, which is exactly what he deals with. And these patients were randomized to receive either a regular formula that was containing arginine and glutamine only, or those with additional omega fatty acid. And they found that when you add the omega, there were fewer wound complications, as you can see, 11% versus 37%, and a shorter length of stay. And subsequently, there have been several studies that have looked into this, particularly in the surgical patients. And they found that perioperative immunonutrition seems to have an impact on the post-operative outcomes, both in well-nourished and malnourished patients undergoing GI surgery, but probably the effect was much more in patients who were malnourished when they were presenting for the surgery. And the focus on the outcomes primarily has been length of stay and cost, which is a big deal. Another study from, it's a systematic review from China, where once again, they found that perioperative immunonutrition is effective, safe to use, and reduces postoperative infection, non-infectious complication, and the length of hospital stay. Exactly what a surgeon wants, exactly what the patient wants. Get out of the hospital as soon as possible and prevent complications, and that's probably what immunonutrition does. Several meta-analyses have been done. As you can see in this one, it was looking at using or supplementing arginine in the surgical patients, and as you can see, it was kind of overall favoring the use of immunonutrition. However, interestingly, when you looked at another meta-analysis by Darren Helen's group, when they teased out and looked at the subgroups of patients, what they found was, yes, it had no impact on the mortality, whether you are dealing with critically ill patients or the postoperative patients, but the infectious complication and the length of stay was certainly less in the surgical group of patients as compared to the overall, critically ill patients whom you see in the ICU. So, yes, there is a need, and it's probably in a select group of patients, which is what we talked about. And I wanted to, since the time is short and we only have 8 minutes, I just wanted to quickly summarize some of what the ASPEN guidelines says. And as I alluded to in the beginning of my talk, basically it is not recommending immunonutrition in the medical subset of patients, on the medical ICU patient, but we feel, it's recommending that we should be considering these formulations for patients with trauma, patients with traumatic brain injury, and perioperative patients who are in the surgical ICU patients. So yes, there is a need, but in a specific group of patients. So they mentioned that although there has been a lot of introspection on whether this should be used in the medically sick patients, particularly those whom we are dealing with in the acute lung injury ARDS group of patients, as of now there is no data to really suggest whether there is a need. So once again, these are the recommendations that confirm that we should be using in patients with severe trauma, traumatic brain injury, and we suggest the routine use of an immunomodulating formula in the surgical ICU for the postoperative patient who requires enteral nutrition therapy. And this is the most recent guidelines published by the American Society of Parenteral and Enteral Nutrition. So, in summary, in view of the 8-minute deadline, you all choose. Do you want somebody who says, yes, we can, or do you want to say no? Okay, so is there a need? Absolutely yes. But we need to use the right nutrient, the right combination. We need to use the correct dose, which none of us know what exactly it is. And this is where the issues come. We use to time it appropriately. And as I said, in the malnourished patient, starting it preoperatively and continuing is probably the right way to do it. So the right patient, right circumstance, appropriate assessment of efficacy and looking at the outcomes. And of course, you need to balance between the harm and the benefit of the immune response. Now, I must admit, should immunonutrition become routine in critically ill patients? Absolutely no. That's not what the question is. The question was, do we even need? And the answer is yes. Okay. So this again is a summary of the recommendations from the ASPEN guidelines, where they say in the surgical ICU, in patients who undergo elective surgery, use arginine fish oil formula because it's data to suggest that there is reduced infection and reduced hospital length of stay by as much as 2.38 days, which is quite significant. However, in the medical ICU, in critical care, don't recommend use of arginine or fish oil formula because there's no difference in mortality, infection, or length of stay. So my answer is yes, there is a need, but might have left you all lost, confused, unsure, and puzzled. We'll wait for the other speaker to convince you. Thank you.